I'm Paul, one of the PGY2s. I'll be going over HemeOnc in the emergency room, powering through 5 topics that you'll see in the ER. So we'll be doing some case-based learning, identifying commonly encountered HemeOnc presentations and emergencies, discussing the management and disposition for these patients. So we'll get right started. So first topic. So which one of these, which white blood cell count result is necessary to make the diagnosis of severe neutropenic fever? Take a look at your options, do some calculations. You have 3, 2, 1, and the answer is D. So this leads me into my discussion about febrile neutropenia. So it's diagnosed as an absolute neutrophil count of less than 500 and a temperature of 38 degrees Celsius for greater than 1 hour, or an isolated temperature of 38.3 degrees Celsius. Patients receiving chemotherapy are at the highest risk of developing neutropenia 7 days after the last infusion, but it can happen before. And this is an emergency that requires prompt evaluation, diagnosis, and empiric antibiotics within an hour of presentation. So you can see here how you calculate it. Basically, you just multiply the white blood count by the percentage of neutrophils present on the differential. So you can see here that only D is less than 500 at 400. So that's why that one is specifically severe neutropenic fever. So this next one is a 23-year-old male with no liver or kidney disease, had chemotherapy 4 days ago, and is presenting with a fever and an ANC of 400. So in this case, what do you think the treatment and disposition for this patient would be? Would it be admission with IV antibiotics, observation with some PO antibiotics, or a discharge with Bactrim? So actually, it's A. And that's because there's kind of 2 different ways you can look at these things. So you have low risk and you have high risk patients with febrile neutropenia. So certain low risk patients can actually be treated at home with PO antibiotics, either with or without an initial IV dose and brief observation period. And so on the left-hand side or on the right-hand side, you can see some criteria. Each of those adds points to an MASCC score. And if it's at or above 21, then these people are eligible for like an observation for 24 hours. You can give them an initial IV dose. And then if everyone feels comfortable, you can give PO augmentin and Cipro. So bacteria are the most common cause of infectious etiologies and neutropenic fever. And if they're low risk and without any of the other comorbidities, these would be eligible. And then Cipro or Levo in our case, we don't have Cipro, with augmentin are the recommended initial empiric agents. And then of note here, the other kind of indications for the other IV antibiotics if you're going to admit the patient and they are high risk. Of note, vancomycin is not recommended unless a suspected skin and soft tissue infection, pneumonia, catheter-related infection, or hemodynamic instability is present. So don't go just throwing vancomycin unless indicated in the situation. So move on to our next topic. So now we have a 23-year-old male with acute lymphocytic leukemia presenting with generalized weakness and muscle cramps. The patient did start chemotherapy 3 days ago, and you can see there the potassium is 6.5, creatinine of 11, and a calcium of 6.3. So which one do you think this patient would require? So aggressive fluids is correct and admission. However, the patient does need emergent dialysis. So this is going over tumorlysis syndrome. So the patient presented with symptoms and signs of tumorlysis syndrome with electrolyte abnormalities and metabolic abnormalities requiring dialysis. So here's kind of what happens in TLS. You have lysis, a massive and abrupt release of cellular contents into the bloodstream after rapid lysis of malignant cells, and occurs secondarily to increased cell death in rapidly growing tumors. And it frequently occurs hours to a few days after initiation of chemo and or radiation therapy. And typically patients in the inpatient settings will get all of these labs taken every day to check to evaluate for TLS. And so potassium, uric acid, and phosphate are all released from cells and then the calcium kind of craps out with the phosphate, and so you have a drop in calcium as well. The diagnosis is obviously with those lab abnormalities or a change in those of 25% in 2 from baseline, and then also end organ damage. So essentially you'll see TLS in high-grade liquid tumors like leukemia with leukocytosis, high-grade lymphomas, and also small cell carcinomas. So just keep in mind that it's not just leukemias and lymphomas. And then you'll see all the characteristic features that you'll see with those electrolyte abnormalities: arrhythmias, paralysis, AKIs, tetany, AMS, and seizures. So the treatments, you have a few options, but essentially aggressive IV fluids and or diuresis at the same time is most indicated, and also managing those electrolyte abnormalities that we all know in the ER, specifically with potassium and otherwise. You can try respiricase, which is helps with the urate oxidase to metabolize uric acid into allantoin, but make sure the patient doesn't have G6PD deficiency, because hydrogen peroxide is also created in that process. And so people with G6PD deficiency won't be able to do it, won't be able to kind of deal with that. Hemodialysis is indicated in these circumstances. So potassium more than 6, uric acid more than 10, a creatinine more than 10, which is what our patient had, phosphorus of greater than 10, and volume overload, or symptomatic hypocalcemia, which also the patient had. Cool. Sweet. So this is our third topic. So 34-year-old woman with a history of AML presenting to the ED with right-sided weakness, trouble speaking, vision changes. On physical exam, you note a right homonymous hemianopsia, fluent aphasia, and dense right upper extremity hemiplegia. Have a white count of 88,000 and 78% blasts. So which of the following is the most appropriate temporizing measure for this patient? A, right. So, you know, instead of plasmapheresis, you actually have what's called leukapheresis. And so this is kind of covering leukostasis and hyperviscosity syndrome. So the patient was exhibiting a specific kind of hyperviscosity syndrome, which is kind of characterized by an elevated serum viscosity. And then in this situation, usually a high white count, usually above 100,000, but also 88,000 is also going to be pretty high. That causes sludging, decreased microvascular perfusion, and then vascular stasis. And so you'll have end organ ischemia, which mimics other disease processes, and you'll see symptoms related to the CNS, eyes, and lungs. And so management depends on the etiology, but supportive care would include IV hydration, diuresis in tandem, and then for this situation in someone with leukemia with leukocytosis, leukapheresis would be something you can do, or even chemotherapy I saw. So basically just like reducing the burden of all those cells with either chemotherapy if you have that, and if you have heme on board, and if that's the institution that they're getting their chemotherapy, or they're working in tandem with the oncologist, or leukapheresis. Always talking to the oncologist is going to be important to make these decisions. This isn't going to be something that we're going to be making a sole decision on. So, but something to keep in mind that these are your options. Getting your specialists on board quickly and knowing what's going on can help with the situation. Cool. So moving on to our fourth topic. So we have now an 18-year-old male presenting with bleeding gums, intermittent nosebleeds for a week, has the rash over there on the right-hand side, and a white count of 6, hemoglobin 13, and platelets of 18. So here, what is your best therapy? What do you think? Yeah, so we would do corticosteroids, because in this situation, we have a petechial rash, low platelets. It's pretty pathognomonic for ITP. And in this situation, it's corticosteroids are initial treatment, and you'll see mild epistaxis, gingival bleeding, or menorrhagia in women of childbearing age. And then with mild to moderate bleeding, such as this patient, you just need steroids. Severe life-threatening bleeding associated is pretty rare. IVIG can be used for patients who have any severe bleeding. But now, say you have a 32-year-old, 20 weeks gestation, presenting after a seizure. No confusion, no focal deficits. You do have an anemia of 7, platelets of 12, and the blood pressure is 118/79. So first, who can tell me on the blood smear, or at Kings County, I literally learned yesterday, you order it as a consultation slide. So just so you know, so if you're not looking blood and smear and not finding it, what are we seeing on the smear here? Right, so we're seeing schistocytes. We're all very familiar, we just went over this. And the answer would be plasmapheresis. Thank you, Camilo. So you'll have the schistocytes or fragmented RBCs, helmet cells, which are indicative of MAHA. And here we have TTP. And guess what? Both Camilo and I both have Google. We have the same exact image. So it's an inherited or acquired deficiency of ADAMTS, which impairs von Willebrand factor cleavage, leading in turn to disseminated formation of platelet-rich thrombi in the microcirculation, wreaking havoc, basically acting as shrapnel against all of your organs and arteries and red blood cells. And look, again, you'll have the classic penta, but as we discussed, it's not always that way. And I actually had one of these patients in the MICU, and a very peppy Plex nurse comes in and sits by the patient and administers all that FFP. And kind of my take-home point, though, is that in the ER, the most important thing you can do before any transfusion or Plex is done is send the ADAMTS13 assay prior, because as soon as you do the Plex, you're basically giving all the ADAMTS, and you're not going to be able to definitively make the diagnosis. And so make sure not only it's ordered but pulled. I was in the MICU and it wasn't pulled, and it was a whole disaster. But anyway. The patient that we had, magnesium sulfate, wouldn't be the treatment because there's eclampsia, or this patient had seizure, but the blood pressure was okay, and it's more consistent with TTP than eclampsia. Exactly, and she had the schistocytes. So don't be like a novice medical professional and think that ITP and TTP are similar, or like, don't get them mixed up. We don't, we're all smart here, we don't do that. So our last topic, we have a 56-year-old male, unknown lung cancer, presenting with dyspnea, chest pain, orthopnea, and palpitations. You have a blood pressure of 70/30, and you have this EKG. And take a look. Go back to the option choices. So which one do you think, based on the EKG and presentation, is the answer? That would be good, yes. And your ultrasound shows a pericardial effusion, so you would do pericardiocentesis. So here we're discussing a malignant pericardial effusion. So you'll see the variation in the QRS, amplitude, pretty pathognomonic. And also, if you were to get a chest X-ray, see the water bottle sign and enlarged cardiac silhouette. And so malignant effusion can be related to the actual cancer itself, or the chemotherapy, radiation therapy, and then obviously there's infectious and autoimmune reasons as well. And then you would drain with pericardiocentesis if their vitals are unstable, and you can get the drainage catheter or pericardial window to prevent any reaccumulation, and of course treat the underlying cancer. But my point for this is understanding what an oncological emergency is. So oncological emergencies are clinical conditions resulting from a metabolic, neuro, cardio, or hematologic infectious change caused by the cancer or its treatment that requires immediate intervention. So essentially, remember that both the cancer and the treatments, you have to think about both and how it affects the patient, because either could be the reason why this patient's presenting with stroke or presenting with a pericardial effusion. Other examples would be the SVC syndrome and like a malignant spinal cord compression. So just understanding that just because you have the diagnosis doesn't necessarily mean that you know why it's happening, and just keep this in mind with patients who have cancer or suspected cancer. And then finally, just since we don't see a lot of HemeOnc here, just some questions to ask patients who do have cancer. So who is their primary oncologist? It's great to contact them, especially if they're at King's or elsewhere. Date of their last chemo is essential for the workup. what was their last chemo. You can kind of either if you know it or you don't, you look it up and see what the side effects are. It's just really important to do. And are they taking any medications like granulocyte colony stimulating factor? What's their previous oncologic course, and then where's their axis? Looking at their axis, understanding where they get their chemo and how they get it is going to be important. And of course, informing the oncologist basically as soon as they come into the ER if there is a concern. So some take-home points. Febrile neutropenia, calculate your ANC if it doesn't come with your differential, and understand there's low risk and there's high risk management and disposition. Think about TLS, your criteria for dialysis. TTP, go to the ICU. ITP is rarely an emergency. And then watch out for emergencies. Watch for ER emergencies, like stroke, cardiac tamponade, end organ damage, secondary to oncologic emergencies. So just make sure you understand everything going on with your patient, both what their diagnosis is and their treatment.
Oh, that was really great.